So my opponents claim that there are no reported cases of abuse. Like stated before, Oregon, or the law gives no authorization to investigate unreported cases, and doctors who violate the law are most likely not to tell on themselves. So, and it contains no penalties for doctors who do not comply with the law. PAD is, my opponents claim that PAD is better. There is an account where a patient with cancer was told by a doctor that it was going to be a painful way to die and advised him to take advantage of the PAD law. The patient took the lethal drugs but didn't die quickly. His wife couldn't handle the situation, so a pro-PAS organization found 2 men to sit with the patient until he died the next morning. The wife became profoundly depressed and attempted to commit suicide herself. So, as you can see, in some cases, PAD is not actually better. In response to the hospice and palliative care, a model for the quality end of life care is available through hospice and palliative care programs. There should be no reason anyone would need to seek PAS. In this view, the focus should not be on legalizing PAS, but improving access to hospice care. There are over 4,000 hospice agencies in the U.S., but because of funding restrictions and the rigidity of the Medicare hospice benefit, requiring patients to have a life expectancy of 6 months or less, millions of people in the United States do not actually have access to these agencies. The linking of PAS to the practice of medicine could harm both the integrity and the public's image of the profession. Historical, ethical traditions in medicine are strongly opposed to taking life. For instance, the Hippocratic Oath states as the Hippocratic Oath, which was previously stated, I will not administer poison to anyone where I ask, and I will be of benefit or at least do no harm. Furthermore, some major professional groups such as the American Medical Association and the American Geriatric Society oppose assisted death. There is also a risk of fallibility of the profession when performing physician-assisted suicides. The concern here is that physicians will make mistakes. For instance, there may be uncertainty in diagnosis and prognosis. There may be errors in the treatment of depression or inadequate treatment of pain. Thus, the state has an obligation to protect lives from these inevitable mistakes and improve the quality of pain and symptom management at the end of life. And lastly, like stated before, scientific advances in pain management ensure that all pain can be managed by using commonly available medications. And the problem is that not all patients are given the correct treatment for pain, and physicians should learn how to effectively cure pain.